This is a presentation on refeeding syndrome presented by Critical Point as an educational activity for healthcare professionals, not intended as clinical advice for individual patients. Refeeding syndrome is a typical pattern of metabolic derangements that occur when previously malnourished or chronically starved patients receive aggressive reinstitution of nutrition, particularly carbohydrates. It is classically presented as a combination of electrolyte shifts and fluid retention that can cause multiple organ dysfunctions and put the patient at risk of death. Minor risk factors for refeeding syndrome include low body weight, weight loss in the preceding weeks and months, a number of days of fasting or nil per os status, alcoholism or other drug abuse, as well as the therapeutic use of various classes of medications for managing of disease. Major risk factors include a significant state of protein energy malnutrition or significant weight loss in the preceding weeks and months, a long fasting or nil per os period of more than 10 days, as well as patients presenting with low baseline levels of serum phosphate, potassium, or magnesium. Therefore, the key patient at risk groups include patients with cancer or other inflammatory or chronic nutrition impacting diseases, the frail elderly, patients with anorexia nervosa or other chronic dieting conditions, patients with a history of bariatric surgery or resective bowel surgery negatively affecting nutrient assimilation, and any patient with signs of malnutrition or with disease-related malnutrition. It is important to note that normal and overweight patients can also develop refeeding syndrome after a period of nutrient deprivation. Under fed conditions and in well-nourished patients, the nutrients glucose, fats, and amino acids are used by the cell to be metabolized to yield the energy needed to synthesize ATP, which is required for multiple cell functions and anabolic processes, and which itself requires particular nutrients for its own production and activity. These key nutrients are the cofactors magnesium, potassium, and in particular phosphate, which is essential for many metabolic processes, including the phosphorylation of nutrients critical to multiple cellular functions. Under fasted or nil per os conditions and in malnourished or nutrient depleted patients, the short supply of these exogenous fuels, glucose, fats, and amino acids, leads the patient to shift to the use of endogenous fuel stores to generate energy. This in turn leads to an intracellular shortage of the necessary electrolytes, magnesium, potassium, and phosphate, often with the initial maintenance of serum levels. Again, it is important to stress that normal and overweight patients can also develop refeeding syndrome after a period of nutrient deprivation. Some of the adaptations that occur when nutrients are deprived from the system include initially a depletion of glycogen stores. This leads the body to rely on protein and fat as main energy sources and is associated with low insulin levels and raised levels of glucagon. These metabolic conditions drive proteolysis and gluconeogenesis, leading to loss of body weight, cell size, tissue volume, and a depletion of micronutrients and the electrolytes phosphate, potassium, magnesium, and sodium. Note that electrolyte levels may often appear falsely normal in plasma because the starved state leads to a concurrent proportional loss of body water. Refeeding syndrome can occur when nutrition is reintroduced to a starvation-adapted patient. The sudden reintroduction of nutrition leads to a form of metabolic stress. This occurs because the new availability of exogenous fuels leads to a sudden activation of previously dormant enzymes at a time when cellular cofactors are in a deficient state. This increase in enzymatic activity enhances micronutrient deficiency and precipitates refeeding syndrome. In summary, the pathophysiology of refeeding occurs where the reintroduction of carbohydrates occurs to a fat-adapted patient. This leads to an increase in insulin secretion, which drives new cellular anabolic processes and at the same time causes cells to take up glucose. Along with the movement of glucose from extracellular fluid into cells, occurs a flux of phosphate, magnesium, and potassium into the intracellular compartment. The new availability of glucose also increases glycolysis, and this, together with the anabolic drive, increases the demand for phosphate for phosphorylation intermediates of glycolysis, ATP production, cell regulation, and anabolic processes. These in combination cause low levels of phosphate, potassium, and magnesium. It is hypophosphatemia that is the cardinal feature of refeeding syndrome and signals imminent and potentially fatal clinical signs and symptoms. Therefore, a low phosphate in a previously fasted patient always requires intervention. So, it is primarily the reintroduction of carbohydrate that precipitates the refeeding cascade. Let us look at this in some detail. The initial reaction is hyperglycemia. This leads to lipogenesis, to depletion of thiamine because thiamine is required for carbohydrate metabolism, a hyperosmolar state, and high production of carbon dioxide. These metabolic processes and features in turn lead to the following potential complications: steatohepatitis, Wernicke-Korsakoff syndrome, and metabolic acidosis, a hyperosmotic non-ketotic coma state, as well as a predisposition to infectious complications because neutrophils function poorly in the hyperosmotic state. And finally, tachypnea, dyspnea, and potentially ventilatory fatigue due to high carbon dioxide production at a time when respiratory muscle function may be poor in a previously fasted patient. Hyperglycemia also stimulates insulin secretion, and both of these molecules have a potent anti-natriuretic effect, leading to renal sodium and water retention, which can potentiate hypovolemia and fluid overload, seen clinically as edema, pulmonary edema, and congestive heart failure. Fluid overload also negatively impacts on gastrointestinal function and can lead to paralytic ileus and multiple GIT symptoms, which make the refeeding process practically a lot more difficult. Insulin secretion drives the flux of glucose, potassium, phosphate, and magnesium from the extracellular fluid into the intracellular compartment. This leads to hypokalemia, hypomagnesemia, and very often hypocalcemia because these electrolytes become depleted in the extracellular compartment, leading to symptoms such as muscle spasm and tetany and potentially life-threatening cardiac arrhythmias, as well as hypophosphatemia, leading to poor ATP production. When this occurs in muscle, it can lead to weakness, poor diaphragm function, and rhabdomyolysis, which in turn can induce acute tubular necrosis. When poor ATP production occurs in red blood cells, this leads to anemia and poor oxygen delivery, leading to hyperventilation and potential respiratory failure, along with ischemia, which in turn can exacerbate GIT dysfunction and importantly introduce multiple neurological dysfunctions, including delirium, coma, and death. Since refeeding is potentially rapidly fatal, it is critical to recognize the hallmarks of refeeding onset. Imminent refeeding is diagnosed by one or both of the following: a drop in serum phosphate of more than 30% from baseline, or a level of below 0.6 millimoles per liter, and or a drop in any other two electrolytes below their normal reference range, for example, magnesium below 0.75 or potassium below 3.5. Manifest refeeding is diagnosed as the presence of the biochemical criteria for imminent refeeding plus clinical symptoms. Some of the monitoring and management basics for refeeding risk patients include the following. It is critical that at-risk patients be identified and their level of risk assessed, as well as their baseline electrolyte levels established and low levels corrected before nutrition support starts. Patients should also be loaded with 300 milligrams of IV thiamine before nutrition support is commenced, and when feeding is initiated, it should begin at low levels and progress very slowly, depending on the level of risk. Patients should have their electrolyte levels monitored 8 to 24 hourly, depending on the level of risk, and provided with high-dose vitamin B co and trace elements on a daily basis. Electrolytes should be replaced regularly according to blood levels, and patients need examinations on a daily basis for the signs and symptoms of refeeding syndrome. Note that all routes of nutrition support can precipitate refeeding syndrome, but patients on parenteral nutrition need especially strict monitoring. Critical Point has developed a refeeding risk management protocol in full, which is available for free access and download from the website. Please visit the Resources tab in order to access it.